So, like I say that the topic is on fetal growth assessment, but what I would be doing here is to try and highlight some of the challenges that we come across in our region in terms of trying to do it properly. The main issues remain the same. To say, most of our women do not book early. You will see from our local data, in terms of when they come, the majority of them. So, assessment of growth in a population that doesn't book in first trimester becomes extremely challenging, and we'll need slightly a little bit more understanding on how to maneuver these pregnancies that come late, so that you can still assess the growth properly. So I will be addressing how best we can manage in these kind of situations where you know that your women book very late. Then the lack of standard approach to fetal growth assessment is one of our main problems. What do I mean by this? In my country, which I think is the same in the region, because we sometimes see patients who have been scanned in other countries coming to us. Our people travel a lot. They may go to Ghana, to Cameroon, to somewhere, and they are pregnant, they are scanned. Whenever we look at the report, to be honest with you, except if they are scanned by fetal medicine doctors, most of them, there will be no reporting of the centers of where the baby is growing. It's a matter of just putting the biometry and then putting head circumference, 32 weeks and 5 days, tummy, 31 weeks and 5 days, femur, 30 weeks and 2 days. This is how they report ultrasound, which to us, we think it's not the right way, because we can't be sure that if the femur measures 31 weeks and 5 days and the head measures 32 weeks and 5 days, we can't be sure where the femur is in terms of the center. So this kind of reporting makes it extremely difficult for people to pick up fetal growth assessment, this kind of ultrasound scan reporting. So this is what I mean when I'm saying there's a lack of standardized approach to fetal growth assessment. Then we have the issue of skill inadequacy. Skill inadequacy means the measurements may not be done correctly, so that growth is either overestimated or underestimated. And then we also have the Doppler skill gap, whereby growth is done, somebody suspects that the baby is not doing well, but because they don't know how to assess the Dopplers, they end up sort of giving a reassuring report when the baby is actually in trouble, and we end up with intrauterine fetal demise, secondary to severe placenta insufficiency. So all these issues are what obtains in our region, which I want to try and suggest some of the solutions, to say what is it we can do. So look at the cohort. This is the private sector data. If you look at the private sector data, we probably more or less mirror what is obtained in Europe, or in the global north, right? Look, 86% of the let's see, what was the N here? Of the 831 consecutive women we saw in the private sector, they were dated using first trimester scan. So they booked in first trimester, sorry. And then if we look at how they were dated, 69% of them were assigned the dates using first trimester scan, which is almost 70%, which to me is fairly okay. But look, they book early in the private sector. The majority of the women, probably these women are more informed and more capacitated in terms of capacity to do things financially. So the private sector may not be the biggest problem, but let's remember that I think Prof. Chauke was telling us that in his country, about 20%, is it 15 to 20% or 20 to 25% of patients are actually seeing the private sector. The majority are seeing the public sector. I think the picture is the same as in our country. Now, we are now going to the public sector data, where more than 80% of the patients are seen. If you look at the booking again, only less than 14%, 14% book before 14 weeks. So this brings a challenge in assignment of the pregnancy deaths. So this therefore means that most of the women who come to us, we cannot assign the dates using the first trimester scan, the CRL, which complicates our issues when it comes to assessment of growth, because the assessment of growth is based on the correct dating of the pregnancy. As long as the pregnancy is not dated properly, we cannot say we want to assess fetal growth. It's impossible. It's near impossible to do so if you do not have the right level of knowledge, which we want to share today. So if you look again here, in terms of how the GA was assigned, when they come to us, we make sure that we verify and we try to assign a due date based on something, because every pregnancy is to be dated. That's the basis of obstetrics. You cannot manage a pregnancy without a date, irrespective of when the woman comes. Every pregnancy requires a date. So how did we allocate the dates in our units? This is a cohort of 10,000 consecutive patients, 10,016 patients. So you can see here that 14% of them were assigned using CRL. Then 43% were to rely on their LMP because of the time they present. If we verify using the Negus rule, only 43% could we adequately use the Negus rule. This is very important to those who still rely on LMP alone. In our hands, LMP passed only in 43% of our cohort. So that means these other ones failed to pass the LMP tests, and we couldn't assign their dates using the LMP. So you can see that we were made to assign the dates in 33% using head circumference in second trimester. We did not use the summary that the machine gives, because most machines will assign the dates. If you don't set your machine properly, it will assign the date using the average of all the measurements. When it comes to fetal growth assessment, you are going to have problems if you do that. That means you are going to miss babies who are not growing. You are going to normalize small babies to make them AGAs when they are small. The same way you are going to make large babies AGA if you use that kind of approach. So you have to use head circumference. So then in 10%, we had to use the head circumference to just assign the dates. So these are the challenges. Real challenges to say is you are going to assign the dates in 10% of your women using head circumference, and in 43% of the women, you have to date using head circumference because of the pyramid of care, which is still in the 1929s in our region. So we need to turn the pyramid of care, and only 2% of our women were to be assigned using the IVF dates, because we now have local IVF teams doing IVF. So when we now look at the diagnoses, say when women come to us, what diagnosis did we end up giving them? So we looked at the 14,844 scans, consecutive scans that were done in our units, and we noted that growth assessment was the commonest reason why they came. As you can see there, that most of them had normal growth, but after normal growth, we have fetal growth restriction. This makes fetal growth restriction the most commonest fetal abnormality in our unit. So fetal growth restriction, this may probably apply to most of the centers in Africa if you analyze your data, or if you scan every woman who comes to your unit, you may discover that fetal growth restriction is the most commonest diagnosis we are making. But before we open the fetal medicine unit, This diagnosis did not really exist in our hospitals, to be honest. It would exist here and there. It was actually a rare diagnosis to be seen. The reason is most small babies were being normalized because of the lack of dating, because of the lack of assignment of dates by people who were scanning at that point in time. So fetal growth restriction is a very important topic in our region, because most babies who come to our high-risk centers where most of us probably work, this will be the most commonest abnormality you pick. Hence, it is important to understand this. In terms of definition, we know that if a baby fails to reach their growth, genetic potential of growth, they are growth restricted. And however, in the setting of fetal medicine, we should always be clever to know that serial growth assessment is probably the best way to comment on growth. So that if we think the baby is not growing well and is stable enough to continue, all growth should be serially monitored to make sure that indeed you are dealing with a case of pathologically small baby, not constitutionally small baby. This is the nomogram of our baby should grow. You can see the +2 standard deviation and -2 standard deviation. We would expect normal babies to grow within this line, following these curves, whether in the middle or on the above the average or below the average, but following this curve. But you will see that some babies may track nicely in the beginning and slow down at the end. This will become fetal growth restriction. This also applies to the babies who are growing within the normal, but who will slow down at the end. So this is why high-risk pregnant women who are at high risk of fetal growth restriction should be followed up. Well, sometimes you may see a baby here, there is a previous history of preeclampsia, or they've screened high risk for preeclampsia. The fact that you have seen them at 32 weeks and the baby is growing well does not mean that you don't have to see them again. You still have to bring them again at 36 weeks and check where the baby is, because the baby could slow down right at the end, because most placentas of these women who are high risk have the potential to fail later on in pregnancy. This therefore follows that an AGA baby is not necessarily not growth restricted. You could have a baby who is growing within the normal parameters, but fetal growth restricted because the growth is plateaued, as you can see there. Then, of course, we also have this small for gestational age who keep on growing at their own pace. And when you look at these ones, we are saying they've shown progressive growth, and we do not think there is any problem. Probably this is just the genes of the baby that are making the baby grow this way. Then, of course, we have the small FGR baby here. We may be using different cutoffs of diagnosing small for gestational age, but we highly recommend ourselves that 10% should be used in our units. One of the reasons why we think 10% is better is because we do not want to miss small babies. Our population is largely black, and preeclampsia is very common in black women, and also placenta diseases are very common in our population, the ones we deal with. So we thought using 10% as our cutoff for screening to say this is FGR, we flag this one for follow-up, it will make us not to miss small babies. I know there are others who are using 5% and for screening, but we use the 10 standard for screening for small for gestational age and eventually diagnosing fetal growth restriction. Then we also use 32 weeks as our cutoff to say early onset and late onset. This is recommended by most guidelines on small for gestational age and fetal growth restriction management. This slide, I'm not going to waste my time. I think my colleague told you the importance of surveillance, Mr. Zangai Sade, that there is benefit in identifying small babies and also monitoring them. There's also this study which was done in England that shows that sometimes if we do not follow up the babies, we can potentially miss small for gestational age babies. Here they were just showing us babies that we missed, say this was a high risk and had serious cancer, and 39.3%, it should be the detection, right? These were missed cases. Then the high risk but had no serious cancer, this was 18%, and the low risk and no serious cancer, and there were 18% of the small babies here, and low risk but had serious cancer, 24%. So there is a benefit in monitoring small babies. Not diagnosing small babies does not have just immediate neonatal benefits, but we'll also look at the long-term plan to say through the epigenetics, the modification of the genes of these babies in uterus, they are predisposed to these lifetime conditions in their adults. So you can see that for small babies, the counseling goes beyond the immediate neonatal, but goes all the way to adult life. These babies will be affected. So identifying them in the uterus will allow adequate counseling of the couple in terms of the kind of lifestyle they have to train the child in to avoid some of the lifestyle diseases like diabetes, high blood pressure, and so forth, because we know that some of these conditions can be modified through some lifestyle activities. Then which formula to use? Because you also have to agree there to say, when you do a fetal growth assessment, which formula are you using? Because sometimes you see scans being done, people do not check their machine to say which formula has been programmed in their machine. All they do is they buy a machine, they plug and just play it, and just scan and produce the weights and produce the results. But you should always check your machine and see what has been programmed so that you can choose the right formula to calculate the estimate of fetal weight, because there's minor variance in these formulas whenever they calculate the estimate of fetal weight. The most commonest formula for calculating the estimate of fetal weight is the Hadlock formula, which I think is used in most parts of the world. The question now is, we have 4 of them, the Hadlock formulas. The question is, which one should we use? We recommend formula number 3 because it has been shown to have the least mean percentage error, the Hadlock formula number 3, which involves head circumference, AC, and femur length. Of course, I know people ask, why don't we use this one? Because studies were done that show that this one is mean percentage error, so that it predicts better the weight of base within 2 weeks from the scan. There's least mean percentage error with this Hadlock formula number 3. This is why we use it. So we'll recommend that if you can set this one in your machine, I think that would be good. It will also allow us to compare our results when you do studies, to say, okay, we are all using Hadlock formula 3. How are you guys diagnosing fetal growth restriction in your country and so forth? So this is why we used it. Then in terms of fetal growth restriction, the other question is which parameter to use. Should we use AC? Should we use estimate of fetal weight? There are studies that have shown that if you do serial estimate of fetal weight measurement, it is good or better than serial AC in predicting adverse outcomes. And also fetal weight estimation is more sensitive and specific than other measures for detecting smallness for gestational age. But however, it can have large random errors, as you are aware that whenever you measure babies around 36, 37 weeks, the level of error you get is 600 to 700 grams sometimes of level of error. Then the other question is which chart, because for you to diagnose fetal growth restriction, you have to say the baby has fallen 10% below a certain chart. There are 3 kinds of charts that are obtained in the literature or in the clinical practice. We have the customized growth chart, with the population-based chart, and the standard chart. The customized growth charts will require some maternal characteristics to be imputed. I've put the ODPOG here, but I think in England they should also be using the growth chart. But the ODPOG is found on the website. It's also another chart where you can input the woman's age, her height and weight, and also the number of pregnancies, and then it will show you where the baby is, like as is demonstrated on this 32-week baby, 34-week baby here, 30 weeks something baby. So this is a customized chart. Then the population-based chart, we are looking at a specific population which is targeting, for example, the non-Hispanic Black. This is a population chart. Then we have the standard. Standard, we are looking at the WHO and also the intergrowth charts, which were designed more like standard charts to say they should ideally fit everyone, and because they are assuming that babies should grow in this way or in a certain way. So the question is which chart to use. You will find out that most machines nowadays, they will come with the Hadlock chart, the WHO chart, the intergrowth, and many other charts. Which one to use? Probably this may be a center-based decision to say, do you want to adopt the intergrowth? Do you want to do the WHO? If you have a local chart, some people have managed to construct their own local chart, population-based chart. Probably you may choose that one. But I just want to put across some arguments on these charts just now. The advocates of the customized chart, they argue that in a case where 14%, almost 50%, who were classified as SGA by the Hadlock fetal weight chart, 56%, 55.6% were not SGA. If the same babies were assessed using the growth chart. So in other words, they are arguing that the more like the standard chart, the Hadlock chart we've used for years, when they started their population, it was more like overestimating the small babies, making more small babies than they should be according to their chart. Then there is also argument that there is better correlation between SGA defined by customized centers and perinatal days than any population-based or one-size-fits-all standard. So there is an argument to say customized charts may be better generally. However, you still have to come up with your own customized chart. You have to do enough studies on your population to be able to come up with your own standard chart. So that means at the moment, before we have our own customized chart, we may still have to use the standard charts that are obtaining to say, do we continue using the Hadlock, which in most cases coming pre-installed in most of the machines, or do we use the WHO chart, or do we use the intergrowth 21st chart? These were some of the arguments that were against the 21st intergrowth 21st, to say the 21st intergrowth 21st showed an unrepresentative rate of SGA, which was 4.4%, and AGA, which was 20.6%, and poor correlation with outcome. These are some of the arguments attacking the standard charts. So what we did is we took the data of 785 patients in our clinic, and we tried to, because in our clinic we've been using the Hadlock charts, more like a standard charts. So this is the distribution of the estimate of fetal weight charts of our cohorts. You can see how they are distributed along the Hadlock chart here. Then we took the same data, then we plotted it on the intergrowth chart. You can see what the intergrowth chart has done here. It has sort of reduced the number of small gestational age, and it didn't probably change much of the large gestational age, but the small babies were greatly reduced if you look at it here in our population. So if we were to use the intergrowth chart, most of the babies we had classified as SGA, we're probably going to classify them as AGA, appropriately grown babies. We did the same with, let me show you. We did the same with the WHO chart. So when we plotted the same babies, please just take note that the intergrowth chart starts at 22 weeks. when we did the same with the wood chart, you can see what is happening here, that early on, we sort of overclassified most of the babies and made them small in the first half of gestation here. But later on, in terms of the small for gestational age, it's almost more or less comparing well with the hard lock which we're using. So for early assessment of how babies are growing, who was obviously going to classify most of the babies you were seeing as abnormally growing. Here, if you look at where the values fell within the wood chart. So this is what we are finding out as we are just analyzing our number, playing with the statistics to say which chart best suits our people. It's a question we have not answered, and we have not yet made a decision to say, do we move away from the hard lock or and adopt the who? Probably we need more cases and make a comparison. This is just a summary to show you the classification now. If we are using the hard lock charts, the hard lock chart is making 12% of our babies. That same is the same cohort of 700. It's what? Yeah, same cohort of 785. So 12% of babies were made small, and another 12% were made large for gestational age using the hard lock. The same population, if we were to use the other charts, you would find 7%, which is the intergrowth. 7% were made small and 5%. So intergrowth will sort of reduce the abnormally growing babies if we were to use it. Then the who is more or less comparing well. There's 9% and 10% of babies were classified as small and large. So far, from our analysis, we think the who almost mirrors the hard lock we have been using in terms of classifying small for gestational age. But the question still remains to say, are these charts not over-classifying or overestimating the small babies compared to this chart? It's a question we haven't answered, but it's a question we hope to answer to say, these babies who are made okay by this chart, are they really okay? In the same manner that are we not overestimating small babies in our population by using the hard lock chart? But this is how the charts compare. But my colleague, I think, will present more data on this. To just round up my presentation, the question now is, how do we then assess fetal growth? Because I've raised a number of issues to do with the charts. I've raised a number of issues to do with the dating, with the way our women present late. How should we assess growth? The most important step is to assess every woman's pregnancy risk, whether they are low or high risk. We assess using history, using the biophysical markers and the biochemical markers. I think Professor Nicolette has presented yesterday on preeclampsia screening and screening for many other things. That has to be done. Then we assign the gestational age. The question is, how do we assign? We'll come to that. To say, how then do we assign? Before you put a probe on the patient, know how many weeks the patient is. Use the best estimate. Do you only rely on the scan? If you can't give the best estimate of gestational age from the information you have obtained, the information include prior scans done. Let me emphasize again, prior scans done. There are colleagues who ignore even their own scans. You see a patient being scanned by one person, every scan they have done has a different due date. You scan somebody 12 weeks, you assign them a due date. You scan them at 20 weeks, you assign them a due date. You scan them at 32 weeks, you assign them a due date. At 36 weeks, you are assigning them the due date. Same person, same sender. Yet the due date is only once. You assign the due date once, and that's the due date you are going to enter into the machine. That's the due date you are going to write on the report, because you can't assign 5 due dates to a pregnancy. To a single pregnancy, to tell a woman that you have 5 days of delivering your baby. I mean, it's not making sense. Right. So perform fetal biometry, and you should measure all these parameters. Please, there are some who just measure the femur length and walk away. you see this kind of reports. You measure the femur length, you walk away and think you've done a scan. Then we have the estimate of fetal weight calculation. Then calculate the estimate of fetal weight using head circumference, AC, and femur length. Then check the nomogram for all biometry. So after doing your measurement, go to the reports, go to the growth charts or the trend for some machines. There is a button called growth charts. Go to that button, check where your babies are on the charts. Sometimes you may have difficulties in reading the centers, but go to the chart. If the SGA, if there is SGA, that is below the 10 center or below the cutoff of the chart you are using, then this woman will need to be done Dopplers. You don't tell the woman the baby is okay, and you don't tell them that they need Dopplers. Because sometimes the women are scanned. You see a woman who was scanned 4 weeks ago, and they come to you with reverse anti-diastolic flow, but the scan they were done 4 weeks ago did not even mention that the baby was small. They were not even told that, oh, your baby is small and you need Dopplers. If you are not in a position to do Dopplers, refer to somebody who can do Dopplers. If LGA, then order GTT so that you can rule out gestational diabetes and refer. If Dopplers are abnormal, then you refer to fetal medicine unit or a specialist center if we are not working at the specialist center. Then if fetal abnormality present, refer to fetal medicine or a specialist center if you don't have fetal medicine in your region. Right. Then how do we assign the gestational age? You have seen somebody, they've come to you for scan, you want to input the gestational age on the machine, the EDD, which will be the basis upon which the gestational age will be calculated. How do you do it? Scenario one, the LMP fulfills the Nugus rule, because we know that 86% of our patients don't come in first trimester. So the LMP fulfills the Nugus rule. Use the LMP to date, because the level of accuracy is better than a late second and third trimester scan if we are to use the LMP. Of course, you can revise the dates depending on your findings if you query that the woman may have said the wrong date. Then if it is in first trimester, then use the EDD you are going to get from the CRL. If she has been done a first trimester scan and the CRL was measured, then ask the woman, you did a scan between 10 to 14 weeks or early scan, what due date were you given? Certainly, the level of accuracy, assuming that it was done in a standard way, is going to be much better than a late second trimester than third trimester scan in terms of assigning the date. Then no T1 scan, LMP not sure, T2 scan done. Then use EDD from this T2 scan, but you are using the head circumference. If you go to your machines, there is a portion where it will give you the option to choose which parameter to use to assign the gestational age. So go to the setup of your machine, look where it says gestational age assignment, and choose the head circumference so that it is already engraved in your machine. Otherwise, the machine is going to summarize both normal and abnormal measurements and give you a summarized and average GA, which will make you miss small for gestational age babies or life for gestational age babies. IVF done, use the IVF EDD to date. But I've seen that nowadays, the team from IVF do not necessarily give the women dates. Most of the women we are seeing of late, they come without any dates from the IVF. They are going to tell you probably the date of embryo transfer. That's the date you can input in your machine. If your machine has got that function to input the date of the embryo transfer. If not, in certain circumstances, you may end up even doing CRIL to date if the woman is not very clear of the issues. But most women will be clear of when the embryo transfer happened, which normally occurs on day 5. So most machines will calculate for you the GA. Then scenario 5, first trimester scan, then you assign date using head circumference. Then you check for biometry asymmetry. If there's no biometry asymmetry, then you can rescan them in 2 weeks to confirm the dates. We're talking of third trimester scans here. Then scenario 6, no previous scan. LMP unsure, high risk pregnancy, assign dates using head circumference, then check the charts if there is biometric asymmetry. What do you mean by biometric asymmetry? The moment you assign the date using head circumference and you go back to your report and the charts, the machine will show you the senders. Sometimes you assign the baby's as dates using head circumference. When you look at the centers, you see that, look, the head is measuring 50% because the one you have used to assign the center, but your abdomen is less than 2%. Certainly there's a problem. There shouldn't be that asymmetry of growth, and these babies need to be evaluated further by doing fetal Dopplers. This is totally different for a diagnostic center. Of course, for a diagnostic center, I believe all women should be assessed by Dopplers so that you can pick up the AGA babies who are otherwise FGR. But for screening centers, women not being in a position to do Dopplers on everyone, it is important to follow this last line to say, if you see that there's asymmetry, Dopplers. If you are not able to do them, refer to a center that can do the Dopplers. This is just to summarize the dating. I've already explained this, that there are errors even in the literature because 50% of women are uncertain of their LMP. As long as you are dating all of our women using LMP, we are bound to miss that, about 50% of our women. CRL is probably the most preferred method to date, but we are aware that about 14% of our women can only be dated using this method. Hence, we need to understand third trimester dating, second and third trimester dating, and these are the levels of error. So if your LMP and the scan you are doing third trimester, here's a discrepancy that exceeds beyond these parameters at the given gestational age. These are the cases where if you are working in fetal medicine, you need to interrogate for fetal growth restriction and also for wrong deaths. But if you are working outside the fetal medicine or a specialist center, these are the cases you will have to refer, because you'll be saying the discrepancy between the dates you are getting the scan is beyond the level of error that is expected, so that you can pick up the small for gestational age babies. I think this is the end of my presentation. Thank you so much for listening.